So I'm going to have my last slide first, and that is one. Although pneumonitis is a less common than any other immune-related adverse event, okay, associated with immune checkpoint inhibitors, the adverse event accounts for most severe and potential lethal immune-related adverse event and one of the most frequent reasons for discontinuation of therapy. Now, that is something I want everyone to keep in mind, that this is not to be taken lightly. Both the available types of drugs that we have, one for the CTLA4 and the programmable cell death CD1, PLD1 and PDL1 drugs, they all can, but it's more common with the ones that we use more commonly and available in India, the immune checkpoint inhibitors. Non-specific interstitial pneumonitis and cryptogenic organizing pneumonia are two most common imaging and histopathological findings of patients with pneumonitis, although considerable heterogeneity exists. The image is difficult to distinguish from cancer progression in lung, and this is very important and often requires a pathological variation. I heard on the passing Pacific trial being maintained, and please remember, with radiation, this phenomena seems to be on the higher part, so keep that in mind. Early diagnosis and use of corticosteroids are the mainstay of therapy. Other immunotherapy services should be considered if corticosteroids are not perfectly working. Treat with algorithm, which I'll talk to you and show it to you all. Drug re-challenge may be reasonable for some patients with pneumonitis, but the risk and benefit should be taken in a multidisciplinary team. The primary aim of this particular disease is to prevent this from occurring, and what it requires that please access your patients. Do not start if there is an autoimmune disorder, there's an organ transplantation, there is acute or chronic infection, there is carditis or cardiomyopathy, even in minimal form, or if there is already an interstitial lung disease, avoid using it and make sure you're watching for your drug interactions, which are very common in this. I'll also tell you some more thing in the era of targeted therapy. Please remember, using a immunomodulating drug after the use of a TKI can actually be harmful and the rates are higher. So very careful when using an immunotherapeutic drug in TKI. So let me tell you something. When does this occur? It can occur anytime, even after the first dose, and it can occur many years after that. Please keep that in mind. It occurs within the first 12 weeks after initiation of treatment most oftenly. And this is also seen that it can occur even 1 year after discontinuation. So on the vigil, whenever you have a patient who is taking immunotherapeutic drugs, more so in lung, please keep in mind that you have to keep a close watch on patients when they occur. The biological effects of the drug persist much longer than the clearance of the drug. Just to tell you, that's the CTCL4 thing. And you will see pneumonia, I mean, anything or lung problems are not common there. But come down to the your PDL1 and PD1, and you'll find out that this pulmonary thing starts anywhere between 3.6 months to 22 months, the commonest being within the first 8 months. Keep that in mind, and that will help us. Also remember that most of these fatal reactions occur within 40 days. Average time is 14 days. So close vigilance is a mandatory in this particular situation whenever we do this. And keep in mind that again, that it is most common when you are using single drug PD1 or PDL1. Now, this is actually the gamut of respiratory toxicities that you see in a lung injury from immunotherapeutic drugs. So you can have something simple as what I just talked, like hypersensitivity pneumonia. This needs to be kept in mind. You can have non-specific interstitial pneumonia. You can have something like a diaphragmatic myositis when just the respiratory rates are high, and you can have hiccup-like phenomena. So keep that in mind. Hiccup can be a presentation. You can have a non-specific ILD-like picture, and of course, an organizing pneumonia. Remember something, re-challenge should always be discussed. I'm reinforcing that. So that's a algorithm. I'm not going to go into it. Most people have it, but do remember any new respiratory system symptoms in a lung cancer patient on immunotherapy, be it cough, dyspnea, or a auscultatory finding. Please remember, you need a high resolution CT, and thereafter, with the help of your radiological colleague, you start moving in. I'm not going to get into these grades, but remember there is 4 grades of toxicity. Each of these toxicities start as grade 1, which is asymptomatic, mildly symptomatic to severely symptomatic. Diagnostic evaluation is based on doing a CT, a PFT, and doing every 6-monthly check for lung infections. Withholding the drug is commonest when we have it. I'm not coming into the right now, I'll come back later. In stage one, re-challenge can be done. In grade two, also re-challenge can be made, but it's important that you don't do it very often. Grade three and four can be severe toxicity, high doses of steroids are required, drug has to be withdrawn. And please remember something, re-challenge is not permitted at the present moment under these situations. Do remember that these two situations call for urgent hospitalization and treatment. So just to tell you in organizing pneumonia, how it looks and after steroids, when we have given it, there can be an improvement. It takes time, almost a month. In hypersensitivity, it takes a longer time to settle down, so that's almost 5 months. While in those non-specific, it actually recovers quite fast. And just to tell you all that please remember that when we have these things, they can take place even in the pleural area. So watch your plates carefully, look at it carefully before we decide it. The other adverse lung events are, one is a sarcod like granuloma. And I want you all to remember this just because, and specifically if you see nodular shadows and you see a lymphadenopathy, you have a macronodular, do remember you need a biopsy to do a sarcoid because the approach to sarcoid treatment is different and not that of a pneumonitis. Serotumoral progression, I'm not going to go into it. I'm sure everybody knows. 25% increase in size of tumor, T cell infiltration into the tumor bed. And wherever this suspicion takes place, repeat the scan after 4 weeks. Clinically, the patient is asymptomatic and has got no problems. There can be airway disease, specifically of COPD and anti-small airway diseases. So you can have a phenomenon like bronchiolitis or a COPD. Keep that in mind when you examine your patient. Pleural effusion is known to be a part of anti-PD-1 therapy. These are usually rich in lymphocytes. They start within 6 to 8 weeks, and fluid regression tends to parallel response to other sites of the thing. This is something that I want everyone to remember. Please remember, very often not talked about in lung injury is opportunistic infection. Almost 15% of patients on immunotherapy for lung do develop opportunistic infections. These opportunistic infections can be of bacterial type, it can be a fungal infection, it can be reactivation of tuberculosis, it can be reactivation of virus. Now, these are more common actually with anti-PD-L1 and combination with CTLA4, where the common pneumonitis is more common with a single drug rather than with CTLA4. Keep that in mind. Don't forget a thing of infection that is there. I'm going to tell you infusion reactions can act for this and call for hospitalization when required. This is just to triage to you or tell you all that we have to do a radiograph and histopathology, whatever drugs we do. So you can have this pneumonitis, you can have the common pneumonitis, you can have a median time of symptom, which I've put it there, and the types of reactions that we get. So it's all a blanket that all type of them can do it. So if pulmonary immune reaction, pneumonitis, our essential is to prevent and anticipate this. Please advise your patients to stop smoking. Make sure that they are vaccinated against common diseases like flu, pneumonia, and pneumococcal, H influenza. I'm thing against even the adult DPT vaccine is given to them because this helps. Dyspnea, cough, wheezing, tachypnea, and tachycardia should be on your heart. Rule out infections whenever you have this problem and have a pulmonary treatment management. Grade one, hold immunotherapy, reassess in 2 weeks, pulse oximeter at rest, and a 6-minute walk test. That's very important. Consider chest x-rays and CT scans. Grade two, hold immunotherapy, infectious workup, consider bronchoscopy and BAL, treat and consider using steroids. Grade three and four, don't use the drug again. Inpatient care, infective workup, empirical steroids, and if it doesn't work and it's refractory, switch over to mycophenolate. Just to put it in a little different way, is new onsets whenever you have any symptom of respiration. Please keep in mind the chance of a lung injury and a differential diagnosis for that. Remember, there is sick contact, and this in today's date is very important to keep that in mind. For steroid therapy, whatever dosing you're using, remember you have to taper greater than 30 days. Long term is required. Don't try a short term, you might create problems. Rapid taper is not advised. Monitor blood glucose and potential adrenal insufficiency and muscle wasting. As anticipated, whenever you're using steroids, you're going to have gastritis or opportunistic infection. So prophylactical antifungal and prophylactical use of sulfur methoxazole trimethoprim is important.
So,
Osteoporosis.
Bhattacharya, can
I,
just 1 more minute or so?
just
Thank
finish.
you.
I'll just finish it
Yes,
up. The toxicities of steroids and immunocheckpoints have to be kept in mind. Do remember that they say that whenever you have an immune therapy, these are patients who actually may have more response, which may not be true actually. If you are steroid refractory, you have the options of using infliximab, mycophenolate, or even IVIG. Only if steroids don't work, we would use them. But on today's date, we have a disruption, the disruption of immunotherapy in treating lung cancer, and we have the disruption of COVID in this situation. So before I end, let me tell you, there is a difference between the disease caused by checkpoint inhibitors and COVID. This is of yesterday, in fact, on the publication from which I'm taking this up to tell you all that please check your D dimer, normal TTP, and elevated IL-6 and lymphopenia to come to the diagnosis of SARS COVID in a patient who is taking immunotherapy. That's just to show you how we would approach it. And please remember, if you don't have it, keep that you might have to treat. But remember, evidence shows that cancer related mortality increases due to delay in cancer diagnosis and treatment during COVID. So don't do that. We do not need to stop immunotherapy because there's no data. Telephone triage is very important. And as I load down those points, follow them strictly. You will be able to go ahead and get this done. This triage is important because if you have this in point, you can go for a telecom. Educate your patients to get in touch with the emergency and with you as soon as possible. So let me try and finish off. Toxic immunotherapy is very different from chemotherapy. This is something we are learning new. Do not close down a toxicity from immunotherapy because a depression may be an adrenal insufficiency. A benign headache may be a hypophysitis. Keep in mind pneumonias and pneumonitis that are there. Multidisciplinary team to take things forward is what is required. And thank you.